Thank you, Vivek Sharma ji, for giving this opportunity. And for this panel discussion, we have four panelists. One is my very good friend, Ganpathy sir. We work together at Tata Memorial, and he continues to support us. He is the CEO of Jascap Foundation. The second person, I know her very well, is Dr. Smriti Khanna, who is a physician like me who has transitioned into palliative medicine, was working in Wardia, now working at Hinduja as in a private cancer center. Dr. Biji works as a palliative medicine specialist in a cancer setting in Malabar Cancer Center. And Manali works as an intensivist and has keen interest in palliative care in the ICU. So we have a diverse group of professionals who would speak on a common theme where we will touch upon advocacy in several settings that are there. Vivek ji, is there a patient or a caregiver representative for this panel?
He could not join, Dr. Saab. Actually,
Okay.
he was willing to, but he could not.
Yeah, no problem, sir.
Yeah.
Okay. So I'll start with Ganpathy, sir. Sir, your advocacy work in India has been mainly through disseminating literature in various language through Jascap books, which is very popular across India, and which has been, I felt, it's very successful initiative. So, can you briefly share your insights about this work?
Sure. Thank you very much, Dr. Naveen, for all the kind introductions. It's always a pleasure to be a part of any panel where you're there. Thank you, Vivek, also. Now, to specifically answer your question about advocacy through disseminating information, I, in fact, come from a family where I had the misfortune of seeing two cancers very, very, very closely. I'm not saying, we could have done something to revive the patient or get the patient back in life. But I still remember what was plaguing our mind is that we could have done something better had we, if we had with us relevant, pertinent information, we could have asked the doctor. And from that is where Jascap is coming from, that we want to channelize our grief by educating others. That's the primary interest of coming with this information. Now, I would say my experience or Jascap's experience vis-a-vis disseminating information for advocacy is pretty mixed. In the last 2 decades that we have been, on one hand, the number of languages and the quantity of books and the oncology centers seeking our books are continuing, and it's in some cases so in the increase. But I'm not sure that the purpose for which we started this information book helps the patient in terms of understanding the basics of the disease, ask relevant questions to the doctor, and thus reduce their initial anxiety as well as also that abandonment of the treatment. So slowly we have started picking up certain loose pieces, and I can say, and we want to go ahead further in that to come to a real conclusion as to what happens. And to that extent, I'm working very closely with Brain Tumor Foundation, where we are doing extensive education. In fact, our in-house doctors writing this book started with brain tumors. So thanks to the consultants there, we are now across pan-India. In fact, before coming to the session, we also had a Brain Tumor Foundation meeting. So there we are scientifically, through patients advocacy group, through patients meeting, we are trying to see when did they get the book, who recommended them to take the book, and how did the information help them. So as of today, I can see that out of every 10 patients, 4 of them have said definitely that they never knew, first of all, cancer can be curable at this stage with proper treatment, with proper diagnosis. So reading this book to a certain extent is giving them some reassurance, some comfort. Also, hematolymphoid, where I had my PhD study about, how these adolescents cope with the challenges of treating. I got many, many responses from there that they never knew that there was a bookstall in Tata Hospital. Actually, they happened to be passing by that annex building, and there they saw the bookstall, and from there they picked up the book, and they said, "My God, if had we known this before, then we would have been much relieved. We unnecessarily got into a lot of negative thinking, and we even at point in time we thought of letting go the treatment. So that didn't happen. So I would say that the experience is very, very mixed, but we are not losing hope. With people like you, we still are going ahead and seeing that how we can, scientifically construct a group and get the data from them to see what the outcome has actually been. I think I'll stop here. Thank you.
Yeah, thank you, sir. And what if I understood you correctly? One of the profound statement that you said was, could have something better if we had information.
Yes, yes,
And
yes,
that is what is your motivation
yes,
to go ahead with the books. And that's a very noble motivation. But you aren't not very sure about the empowerment potential.
yes, yes,
Literature, you started with the aim that it will empower
right.
them to engage better with the doctors, ask questions, make better decisions.
Yeah, yeah.
So, but I feel that it does, and it has, and I think that's a way of advocacy, isn't it? Through
Yes.
literature,
Yes.
when they say advocacy, it need not be always advocating directly. There are
Correct.
many ways of advocacy.
Absolutely, absolutely. Sir.
And this is a very novel way of advocacy is to create literature, and this literature having this empowerment potential, isn't it? Yeah.
Just I want to add only one thing
Yes,
that
yes,
in the
yes.
last recently we have come up with videos on head and neck cancer specifically with the help of Tata Medical Center. So what they have done over there is they have created a business card kind of a thing which is QR code. So any patient who is getting registered for the treatment, along with the file, we also give the QR code in the form of a visiting card, and they can, wherever they go, they sit at home, they can see the videos, and especially about speech and swallowing therapy. What happens to the head and neck cancer patient? And we have been getting very, very positive reports from the patient group over there. So yes, thank you, sir. Yeah.
Thank you. Other work that I have closely witnessed in terms of advocacy is that you have a unique talent of connecting philanthropy to care.
Yeah.
So you are, when I say philanthropy, it is not extracting money. It's actually people who have the resources. You are giving them an opportunity to use those resources well.
Right.
And not everybody can do that. So can you briefly let the audience know about your successes and challenges in connecting philanthropy to care? It need not be palliative care alone, but to all forms of care.
Coming from a background of psychology, I always thought that if I have to work for the patient's benefit, then I must know where my resources are going to be used and how is it going to benefit the patients in a very measurable form. So towards that, first thing, of course, I started off working with hematolymphoid, and there I was, looking at the ALL patients. But very concretely, I had a huge discussion with the consultant of the bones and soft tissue, because I learned that that's one of the cancers that comes in that adolescent age or teenage age. And I also learned that how early detection and treatment can help that patient come out of it. At least 7 out of 10. And also I learned that this was one of the cancers where, the side effects or the treatment related burdens are much lesser, and cost wise also it can be contained. So that's when I first started supporting the adolescent group of bones and soft tissue, cancer patients. And I'm very happy to say that I could really, really see, we consciously, with the help of the consultant, looked at the early diagnosed young boys and girls, because I looked at it that my philanthropy should not result in something only quantitative, but definitely qualitative. How can my organization return the support which the family would otherwise lose? And adolescent who's in the throes of his life, his dreams, his aspiration, very, very important support to the family is very crucial. That's how I started. So like this, the next group I went is to work for the thoracic department, where they started off this, crisotinib molecule. I was told that they have an arrangement with the pharma organization that NGO funds one strip of 48,000. Against that, they will get the, the pharma company will give the other one. And therefore, I studied that. On the other end of the spectrum, this is adolescents and teenagers who are settling their life, and they're 55, 56-year-old, when they have kind of worked, most of their life, and they've consolidated some money, and they want to waiting to use that money for their son's higher education or a daughter's marriage. This blessed disease comes, and it's very, very difficult. So I said, how do I give the support back to the family? But I spoke to the consultant. He said, what can happen with this is they can at least lead 3 or 4 year productive life. They can still work. That's what they do. Then I went and spoke to the corporate and discuss with them how we can look at truncating the superannuation benefit that they would get. So typically you have to be 60 years old. Can we look at somebody at age of 58? Probably you might not be able to be productive. Some way of concentration that you can do. So all these ways, it did not only look at money, funding, that of course is there even in palliative care, but essentially these are two cases that I can look at. One is adolescent giving support to the family, and here at the other end of the spectrum, 55, 56-year-old, where we are trying to preserve and see how we can help that gentleman or the breadwinner of the family to realize some, unfinished business or dreams that he would have. Now, coming to palliative care also, for example, as we all know, Tata is a very high volume, high dense, patient cohort we've got. So they started having home care. Of course, they've been having home care for the last decade, and we have been doing a wonderful job. But we realized that as the patient become more and more advanced, they're coming to the hospital financially also, otherwise also was extremely getting difficult. So we funded one of the projects where we said nurse-led home care. We essentially, the nurse would be part of the group. Every Wednesday we will have a triage system where advanced care patients are being highlighted identified, and this nurse would coordinate with their family physician to ensure this patient, whatever is symptom is causing him trouble, is taken care of immediately. So that we will also trying to preserve the quality of life. And I'm very happy to say that this nurse-led home care movement really showed us how this perceptibly we can make this difference. So we kind of enrolled 87 family physicians for the patients who do not have a family physician, and the nurse and the hospital together handheld the patients through these facilities. So at least more than literature, I think this philanthropy has really brought in some satisfactory, measurable outcomes for patients' quality of life.
Thank you, sir. Thank you for your insights and wisdom. Much appreciated. I'll go to Dr. Smriti Khanna. Now, as a physician, you have transitioned into palliative care, and you are now working at Hinduja Hospital, Mumbai. How are you able to advocate for palliative care among the colleagues? It's a multi-speciality hospital, so you would probably interacting with the many different specialists. How are you able to do that?
Thanks, Dr. Naveen, for that question. And thank you to Mr. Vivek Sharma and Cancer Conclave for having me on. I think that one of the ways to advocate for palliative care is to understand the sense that patients in different setups actually have different palliative care needs. And that is something that my transition from home care to sort of government patients in government setup to patients in a private setup, that actually taught me. And so what I have found quite useful is when I see a patient that has been referred, trying to zoom in on that one or two key things that would be very important for that patient palliative care wise, and then going back to the referring consultant and then speaking to them about them. This kind of gives them extra insight into the case. Many a times, oncologists are quite busy and may not have the time to look into the other aspects of it. So, for example, if I see a man living just with his daughter, and that's just the family there is, I know that teenage daughter is going to require a lot of extra additional support, and then counseling is going to be something that's going to be beneficial. But the treating surgeon may not have the time to be able to kind of focus on that. And so going back to them and telling them that this is what I feel was most essential, and this is how I have liaisoned with the counselor or with a home palliative care service to be able to get in touch with this family. Another way is something that we have started at Hinduja is setting up joint clinics. And this is something that that can be useful in both oncological as well as non-oncological settings. Most joint clinics have two doctors sitting together and looking at patients from different kind of systems or different frames of mind. And that has been also quite interesting in changing the patient's thought process also about what palliative care is and how useful it is for them, and also to some extent changing the doctor's point of view. And then the third thing I think that has helped is patient-led or volunteer-led support groups. So having the support groups stay in touch with doctors, on a basis like say once in 3 months or once in 6 months. So having different support groups stay in touch with doctors, and the support groups also themselves advocate for the use of palliative care or how useful they found palliative care to be, and that feedback when it reaches doctors directly really helps.
Thank you. Just a follow-up question about the joint clinics, which you mentioned. So when you sit in the joint clinics, and I've been many joint clinics, the predominant discussion is around the disease. There is very less discussion around the person who is having the disease. How is that barrier you are able to overcome?
I think that when it comes to long-term treatment and different treatment options when they are there in front of the patient, that is where I would say that the primary doctor kind of sort of gives treatment options and then waits. And that is kind of my cue to, get in and say that, okay, this is what we have. And now I want you to know that we don't have one right answer over here. And usually what families do is that they kind of take our help and choose what is best for them based on their situation. It could be finances, it could be social support, it could be distance from the hospital, it could also be goals of care. And that is where I can then introduce the goals of care concept.
Right. And often, maybe Hinduja is an exception, is that private institutes are very return of investment in terms of revenue rather than value. How would you be able to advocate for palliative care where value supersedes revenue in terms of return of investment? You are the investment there, isn't it? So how would you be able to advocate that for the administration?
Couple of things, I think. I was lucky enough to have a predecessor who laid the base, sort of made a case for palliative care when I joined Hinduja, and they were already convinced when they came in that they needed a palliative care person on board. But I think that what happens is that when you put in the years of work collaborating with different physicians, it could be ICU, it could be the oncology department, it could be the non-oncology department also, they then begin to advocate for you. So I was fortunate enough to have enough sort of buy-in from other senior doctors in the hospital, who then said that we are glad to have palliative care on board. We would like to have palliative care on board because we have seen how it works, and we have found that it has been beneficial for the patients. One other thing that we noticed was, of course, this was informal, that after the involvement of palliative care, patient complaints against hospital administration reduced. And this is something that we then brought to the notice of authorities. And I think that was also a good selling point.
And thank you so much. A very similar thing that we have noticed is that our discharges against medical advice came down, like how you had mentioned about. Next question is to Dr. Biji. There is so much of evidence on integrated palliative care in cancer. So much has been written since Jennifer Temal's time in the last decade or almost 15 years. How are you practically able to do that or advocate for that among your oncologists in the public cancer institute?
Thank you. Thank you, first of all, Cancer Conclave, for giving me this opportunity. And thank you, Dr. Naveen Salins. Like you said, I work in a tertiary cancer center, and we have all the oncologists, surgical, medical oncologists, radiation oncologists, all working. And the thing is that in a patient, and we work as an independent department. Cancer Palliative Medicine is an independent department in my institution, and we have a stoma clinic, we have a lymphedema clinic under us. So when any patient comes for treatment to any of the oncologists, these patients would be referred to us in the initial few visits itself. If the symptoms are very much, the first visit. Otherwise, depending upon the patient load, it is actually we have it's an adjustment, like they call us and ask if you're free, all that. Otherwise, the intention is that the first visit, the patient has to see a palliative care physician. So, even in the ward, when the patients are admitted, maybe under the other oncologist, but still for their symptom control, we are always pulled in. We get a reference, we have to see them during radiation or during chemotherapy, whatever be their symptom problem, we have to be with them. So we actually, for their treatment, it's a hand-on-hand we go with the oncologist. Secondly, as as part of our Kerala government's palliative care policy, awareness on palliative care is given to all the staff in our institution, right from the security, administration, or all the medical people, even up to the cleaning staff. Everyone has to get an awareness session on palliative care, and that is given regularly in our institute. Third, all the residents, our director is very, all the residents, we have DNB courses, we have fellowship courses going on in oncology departments, surgical, radiation, all that. So they have to compulsorily, they have to undergo a palliative care course. So mostly they take the IAPC course, which is run thrice in a year, or they have to undergo some foundation course in palliative care, which we do in our department. So that is one more thing. So as a result, it's a very good input we get from these residents. So the care of patients is much good after that. We have a nursing college attached to our institute. So the nursing students, they keep coming in for their practical work. So we are very sure that when they come into our department, we definitely will give one session of awareness class for the budding nurses also. Okay, and another thing is that we are also a part of the medical specialty, the multi-specialty board which occurs in our institute. That is there every day after the working hours, like in the evening, we have a multi-specialty board, and palliative care physician is also a part of that multi-specialty board. And now when the patient is inside the hospital, definitely palliative care goes on along with the oncology treatment. And once the patient has to be only on palliative care, then what we do is, we have a very good network of palliative care in Kerala, very good network. So we can very safely hand over our patients to the local palliative center. Now, who are the people who help us there? The volunteers there. With this such a good network, we have an innumerable number of volunteers working in palliative care. So, and these volunteers do come to our hospital also for some training purpose. In between, we give them training. Also, we always have a good relation with them. So we have their address, we have their phone numbers with us. So whenever we have to refer a patient to the nearby local palliative center, we contact them and we hand over them the patient, and so that the patient is very safe. And any concern they have to, they have to come back to us, like when they have to get sometimes they might have palliative radiotherapy or something to improve their quality of life, even after they leave the hospital. So in that time also the volunteers, they speak to us and we ask them to bring the patient and we give them care after that. So definitely oncology, and I have a lot of support from my oncology team, and everyone, I'll tell you, they are aware about palliative care, and they give me good support in taking care of their patients. And we do research activities also along with them. So like in our stoma clinic, we do research activity and we show the quality of life of stoma patients when the patient is being addressed by a stoma nurse who is in our department. So the surgeons are shown that. So because of that interaction and showing the research activities, we have the result. So we have a very good, I mean, we all work together for the patient. I'd say it's like a teamwork, we say, absolutely, it's a teamwork. Another thing is about the pain. We know it's the most distressing symptom for a patient. So once a patient is into our hospital, the pain assessment is done. On the case sheet, the pain score is written. In the ward, regular. It is every shift the nurse goes. I mean, the pain score will be also assessed like they assess the other vital signs. We say pain is a fifth vital sign. Definitely in our institute, it is the fifth vital sign. It is recorded in the case record. And we do have an uninterrupted supply of morphine. So pain management is absolutely fine in that respect. So I think
Thank you, ma'am.
integrating is a...
I have one more follow-up question. Sorry to interrupt you, which you answered mostly, is in terms of community advocacy groups, which you mentioned a lot with the volunteer work that you are doing, and Kerala per se has a lot of the neighborhood network program.
Yes, sir.
But
Yes.
are there any specific community advocacy groups for oncology that exist, which helps the patients and their families?
One is about this neighborhood network in palliative care, that is IAPC Kerala. That's an umbrella organization for coordinating all the activities in the 14 districts of Kerala with the help of these palliative volunteers. So in our district, we have around 450, around 500 volunteers, I should say, because we have more than 60 palliative care units in our own district. So I told you the volunteers, they definitely help us in that. They undergo training, and they take training from our center, they take training from IPM. And so they keep increasing their number. And so we have a very good help from these volunteers. There is another one, I should say one consortium, which our director has created. It's called the Kannur District Cancer Control Consortium. So though the main objective of that consortium is early detection and prevention of cancer. But most of the members in this consortium are our palliative care volunteers and the survivors of our cancer. So they themselves are an ambassador for that, to bring in our patients and tell them what we do. So because they're all palliative care volunteers are also a part in this KCC, what we say, Cancer Control Consortium. What they do is that they come to our hospital, they sit in the help desk. So whenever a patient comes in, they take care of them, they help them to fill in the forms for these schemes, opportunities which is given to them, financial support, then how about to go into the hospital, whom to contact, how to contact. All this is done by our volunteers and the support group people. And they also bring in certain funds from the other organizations. When they find that the patient is financially poor, they try to bring funds from the other organizations and help them complete their treatment. Recently, I'll tell you one more thing they have brought in is something called the Birthday Challenge, one new program. So what they do is the nearby schools and colleges, that is each student, when he spends some amount for his birthday, celebration of his birthday, one small amount he donates to our institute for the poor patients fund, into the poor patients fund, which goes, and that is utilized for our patients treatment. So that is one group. Then I told you we have these support groups. We have support groups for various cancers, like head and neck support groups. We have gynec malignancy support groups. We have stoma clinic support groups. And all these people, we give them some rehabilitation program also. Like recently we had, not just 2 years back. So they've been learning how to do mural painting. And it's a distraction from their work, but it adds color to their life, I'd say, because I have witnessed them painting that. And we kept an exhibition for that, and they were able to sell out those pictures, and they could earn some money for themselves, and they had also given some for the poor patients fund. So I should say that
for your input. Sorry, because of the paucity of time, I have to ask the next panelist, but I can clearly see the diversity of work and the advocacy that happens. It's really a multi-level and multifaceted, and very thankful to you for all the insights. Going to the next panelist, Dr. Manali Patel. Ma'am, you work in the ICU space, and this is some work that's very close to my heart. So as a critical care physician, are you able to advocate with your colleagues for appropriate care of the patients when ICU measures are unhelpful? You're muted probably. We are unable to hear you. Vivekji, can you hear?
No, Dr. Saab, is your computer connected with the speakers?
Are you able to hear?
Better.
Yes,
Yes,
now we
yeah,
can
now
hear.
we can
Yes.
hear. Now we can hear.
Okay, okay. So, this is the most difficult group to advocate. And let me start with my short story that I have started with critical care in 2005. And from 2005 till 2018, till I went to AIMS and attended Dr. Sushma Bhatnagar's lecture, I wasn't really aware of actual palliative care, which I can offer in the ICU. So bitter truth start with me that in 2018, I understood about palliative care, and that point of time, I realized that I can do something for my critically ill patients. And still there is lot of, like, it has been included in our critical care curriculum. Palliative care has been included, but still lot of things to be done for intensivists as well. Unfortunately, still intensivists, they do feel that death is defeat, and they are not able to accept that defeat. So we need to work something on this where we do understand that just correcting physiological parameters, just correcting correctables are not going to be helpful. In patient, they have started with absolutely compromised quality of life and they are going through the critical phase of illness. They will go back home with a poor quality of life once they discharge from the hospital. And unfortunately, these parameters, many of us are failed to understand or assess. And we are the people who guide families for going ahead with the aggressive treatment. So sometimes I feel that sometimes family insist us for aggressive treatment, and sometimes we are unable to convince ourselves that this is the point where we should just consider comfort care. So right now I'm doing two different jobs which are absolutely opposite to each other. So whenever these are critical patients who come to me and they should do everything aggressive, I convince them for aggressive treatment. And there is a point where I feel that now aggressive treatment is just deterioration their quality of life and probably deterioration in their quality of death as well. At that point of time, I put my palliative care physician forward and I offered them that at this point of time, I think it's right thing to stop. Right thing not to go ahead with the further aggressive treatment. But unfortunately, it's still...
You are doing your part, but how are you advocating for the cause with your colleagues?
Sir, advocating is mainly communicating with them, but this is the most difficult part. I feel it is easy to advocate patient and their families. It is difficult to advocate different specialties who are involved in the care. So
Right.
still I'm trying to find out better ways how to advocate them. But probably more awareness about palliative care and more acceptance of death, more acceptance of physiological limitations of the treatment. We need to understand that these are the limitations and we should not be putting our limits. We should not be stretching patients' financial and physical limits, and we should not be stretching our expectations as well.
Right. Thank you, ma'am. A follow-up question to what you just mentioned. Do you think that the patient families, I'm not saying patient, families are empowered to ask for palliative care in an ICU setting?
Unfortunately, there are two diverse groups of families are available outside the intensive care unit who are waiting, who are in that waiting area. So there are families who would like to do everything when things are non-salvageable, and there will be different group of families where would not like to do anything when patients are salvageable. So still these two diverse group are very difficult to communicate with, and still I feel that there is not enough awareness for patients' families as well, that they have option to stop somewhere. And whenever I have faced challenge at that phase also, whenever I'm trying to tell them that these are the options we have available, that we can refuse for invasive ventilation, we can refuse for further aggressive treatment. But many times there is improper agreement between the family members. One family member would like to go ahead with the aggressive treatment, and other family member would like to go ahead with the non-aggressive treatment. That point of time, it becomes difficult for us to get them at the same point where they get into the agreement and go ahead for one single mode of plan of care. And unfortunately, same disagreement persists for specialty consultants as well.
Right.
So
Thank
we
you
need
so
to have more awareness about palliative care in critical care as well.
Yes. Thank you so much, ma'am, for those insights. And these are all coming from your experiential account of working, isn't it? And we are very grateful to you. So what we saw in today's panel was a very diverse advocacy. When we understand advocacy, we always have a very one-track thought about advocacy. But advocacy can be done at many levels and in many ways in our own work. And what we saw Dr. Ganpathy doing advocacy through literature and philanthropy. Dr. Smriti Khanna doing advocacy in a private setting through interacting with various clinicians through joint clinics. Dr. Biji doing advocacy at community levels, and especially for the vulnerable groups, and how she liaises with many people in the society and how the care is being provided. And Dr. Manali Patel, how she does her own advocacy in a very unique way in an intensive care unit. So with this, I end my session moderating. I'm very grateful for all the panelists on a Sunday afternoon, now Sunday evening, to participate in this. And thanks Vivek and Dr. Kumar Prabhash and the Cancer Conclave for this opportunity. Thank you.